So good morning, good afternoon, and a good evening to everybody all around the globe. And welcome to this MOH Talk on our platform, Medical Online Hub by Sigvaris Group. Thank you all for joining this special pre-event for the 27th European Vascular Courses 2024. Let's hit the road. Let's travel together on the road to Maastricht. Special warm welcome also to the great set of speakers and panelists in here. And I do not know why you, the participants, joined today this pre-event. You might write this into the chat function that you see below because we want to interact with you. We also invite you to ask your questions in the Q&A section below. So today you can get a lot of answers from experts from all around the world. And as you may write your first comments, I would also just like to personally tell you what motivates me to when I think about the EVC. First of all, the EVC is truly devoted to education, to training, and to sharing knowledge. It's not about showing off. It's about sharing and developing skills. And I love the beautiful diversity of people from all over the globe, from different age groups, from different backgrounds, and all they're coming together with the intention to learn and to develop themselves, and in the end, to have a good patient outcome. The EVC, for me, it's a great mix of state-of-the-art lectures with a broad spectrum of vital topics, including arterial, venous, and vascular access, cutting-edge cardiovascular matters. And additionally, there will be more than 300 workshops. It's very hands-on and ranging from surgical anatomy, diagnostics, medical management, decision-making, up to open and endovascular techniques. Next to that, I enjoy meeting and collaborating with the engaged team around Professor Jacobs in Maastricht. Both the medical experts and the organizers do a truly excellent job. And lastly, Maastricht is by far my favorite place in the Netherlands, and I highly recommend to come there. Today, we are happy to give you a first insight on what you can expect during the EVC. This meeting here, it's just an appetizer that will give you the taste of the EVC. It's a homeopathic portion of what you will be able to experience in Maastricht. For the full experience, there is no other way than to register yourself for the EVC and to come to Maastricht. And of course, Sigvaris Group will also be on site. We will have a combined workshop together with Philips and Kreuzler. And we are really grateful this time to have this great collaboration and a joint workshop with different industry partners. And really happy that also something like this is happening and possible at the EVC. It will be about a holistic approach to venous leg ulcers. It will be a real hands-on workshop, but it will include both diagnosis and sclerotherapy, the treatment options, as well as the diagnosis-related compression technologies that come along with this. So please don't miss out. Be part of this great event. Book your seat for this workshop at the EVC app or at the EVC website. And just remember, we just have a limited number of seats also in the workshops. So it's now the time to go in there. And with this, I pass the stage to Dr. Uma Jalai, head of the European Vascular Center Aachen Maastricht and director of the EVC venous team. And one of the highly engaged minds behind the EVC that make it possible. Thank you so much, Uma, for being here, for moderating this event. And I would just like to start with a question. Uma, what can we expect this year at the 27th EVC in Maastricht?
Thank you very much, Dirk, for the kind introduction. And I think you already mentioned the main points and the focus of the EVC. First of all, I thank you, Dirk and Mahmoud from the Sigvaris team for supporting this meeting, the Road to Maastricht, supported by Sigvaris, and also many thanks to my co-moderators and speakers, Rebecca Ricci, Joanna Storino, Tobias Hirsch, Makis Avgerinos, Nikos Lapropoulos, Suat Toganci. I didn't know, Suat, you have a German flag behind you. I thought you are from Turkey. And Ahmad Gavesh, who cannot join us, unfortunately, today. So EVC this year, from 3rd to 5th of March, we have the 27th year of EVC in Maastricht. We would expect this year probably 1,800 vascular surgeons, IRs, angiologists, phlebologists, and also some colleagues from internal medicine, and many nurses. So before COVID, we had 2,200. And, you know, with COVID, it went down. We had 1 year, 2021. It was with the green screen, the remote part. Then we started with 1,200. Last year, we had 1,500, 600. And this year, we expect people more than 1,800. It consists of 4 parts. The main 2 parts are aortic arterial, peripheral, and the venous. But we have also an access part and also a cardiac part. So the focus of EVC, Dirk, is its workshop. So just focus on the venous. We have 26 special focused venous workshops. So we have workshops of holistic approach for venous ulcer, supported by you, by Sigvaris, Kreuzler, and Philips. Just consider 3 companies. One is Philips, who is involved in imaging and intervention, and Sigvaris, who is focused on compression. And we have also many workshops regarding only imaging, like IVUS. We have Duplex workshops for superficial and for deep venous system. We have stenting workshops. We have treatment of DVT workshops, which mainly is being led by Makis Avgerinos. So I think everybody will find something, regardless if he's an interventionalist or working in a private office. So I would appreciate if people can find the homepage, find the EVC 2024 app, and just consider if you are registered for the EVC, you can book and register for each workshop, regardless venous or aortic and peripheral or access, for free. You can go to 5, 6, 7, or 10 workshops. So I think that is what I can add to it.
Perfect. Yeah. Thanks, Umar. I think it's a full buffet, a full plate. Yeah. So with this, we come to the first part of this MOH talk, which is over to you.
Thank you very much. I am not going now into the detail, because many people here maybe are interested more for a holistic approach of ulcer, which is the second part, or maybe the aesthetic phlebology. But we have many colleagues here, Tobias Hirsch, Rebecca, Joanna, Nikos, who are also very familiar and experts in treating also the superficial system. So, and maybe Makis and me focus on the deep venous system. I have also included 2-3 slides about the last years of EVC, and maybe it gives you an insight about the Congress. So I'm sharing now my screen with you. So I hope this video is running now. So that was a short video just showing you that those workshops, we have presentations in the workshop, but we have also hands-on courses. We have suturing courses, cardiac courses, aortic, but also focused venous. So that is the next video. That was 2022.
Oman, do we have to book in advance for the workshops, or we book on site? And how many people
can book
attend?
in advance, and that would be nice if you book in advance. And again, if you are registered, you can book any workshops you like for free. Please use the app or go online to the homepage and register for the workshops. But you can also register inside. This is our venous room. As you can see, always full. So for the venous part, compression, aesthetic phlebology, superficial treatment, deep venous, acute, chronic, coil embolization. We have a part which goes from 8:30 to 12, a scientific session, and then the workshop, focus workshops will start. So please register. And again, for the southern countries, there is a special reduced registry fee of 200 euros. If you register, you can use all workshops for free. This is the a picture of the venous team for 2024. And you see Professor Avgerinos, Mo Barbati, who was sitting next to me, Stephen Black, Suat Duganci, Rick de Graaf, Jorinda von Lanen, Michael Lichtenberg, and Jerry O'Sullivan. All of them will be there, plus many other venous KOLs, as you see also Mrs. Rebecca Ritchie here, and also Tobias Hirsch and Joanna Ostorino are our faculty. We have 42 or 43 venous faculties, KOLs, and they can address you and lead you in the workshops. I would appreciate if you go to the homepage and find the right workshops for you. This is just a picture focus of the Sunday workshop, and I focus on the holistic approach to venous ulcers, state-of-the-art diagnosis and treatment, led by Zigwaris, Kreuzler, and Phillips, with brilliant moderators, as you see, Berg, Hirsch, Storino, Ricci, and Mahmoud. So go inside, find it, and register for the workshop. Now I start the main topic. We are now focusing on chronic venous obstruction. These are signs and symptoms of chronic venous obstruction, or PTS. Very special are the collaterals, as you can see. For the diagnostic, we use always Duplex, and also we have a focused, deep Duplex workshop supported by Phillips and Professor Doganchi Suat, who is here. And we have also a superficial focused Duplex workshop. We combine always our Duplex with MRVs. Also, we have in our workshops talks about different kind of diagnostic tools, the differences between MRV and CTV, or if we go farther, you see how to manage a venous map after performing a Duplex. In this patient on the left side, you can see a total chronic venous obstruction, iliofemoral, or the patient on the right side, also a chronic venous obstruction, but with a very good inflow, which is being detected by a good Duplex. So in the Duplex workshop, you can learn those techniques. And here, just showing you that we use always in our deep venous procedures, independent if treating the acute DVT or chronic, we use IVUS. So we have also focused IVUS workshops. We have also a workshop which deals with 6-7 difficult IVUS or cases in whom we show how to use the IVUS. Any questions, any remarks?
Human, it is obvious that appropriate planning is the cornerstone of success. So I see you get a thorough Duplex, you get an MRV, other people might choose to get a CTV, and you always use IVUS. I mean, yes, these three always need to be there before you do a procedure.
Absolutely. So I think also we are going to talk about these things at EVC. Yes, that is the key step for preparing a good treatment. I come to the post-op treatment, in which anticoagulation and compression is a key. But here, as you mentioned, Makis, the planning for a treatment of a DVT and the chronic venous obstruction is key. You need to have a good Duplex and a venous map, plus a cross-sectional imaging. If you have it available, go for MRV, you reduce radiation exposure. But if you don't have it, also a good CTV will work. In the OR, you need IVUS. This is our non-hybrid OR. C-arm, Duplex, IVUS belongs to a venous intervention. And those are pictures of our hybrid OR. again, Duplex is the main key. Just today, I came back from an intervention of a 7-month-old boy. And I did the intervention today, 3 hours with neurosurgeons. They need a ventricular shunt, but they couldn't put the shunt into the right atrium. That was performed 3 days ago. And then we made a CTV, and we saw that everything is occluded due to previous central venous catheters. So today, we just made the cut down. We approach the catheter, open it, put the wire, re-canalize it, and now this very young child has now the access and his shunt working. So while, of course, many cases are easy, you go through the pathology with some wires and catheters, but also we will learn how to traverse difficult pathologies with different kind of catheters, support catheters here, Triforce, or here just showing you sometimes we need also a sharp recanalization. You see, I took a 0.18 wire from the back side, from the sharp point, and I took a needle holder, and I am doing the sharp recanalization. Or here, in some cases, we need even a TIPS needle. I think this is with double P. So we put the balloon from IVC, and from iliac tract, we ruptured the balloon to ensure the wire is going to the IVC. Just showing you some insights of what we are doing. Or in some cases, we need also a hybrid approach, not only with wires and catheters. In very seldom cases, we have to open the common femoral vein and or perform the endophlebectomy. We will also talk about those techniques.
Kuman,
yes.
And this is great, but can you explain to me in this course, particularly the trainees and the younger people, how they're going to learn, what they're going to take away?
Yes. So first, Nikos, they can pick up first what they would like to learn, because we have aortic sessions, we have peripheral sessions, we have venous sessions, and venous we have superficial and deep. So let us say somebody is interested in deep, he can learn really from diagnostic approach, indication making, like a Duplex course, like IVUS courses, like holistic approach, but also technical tips and tricks of recanalization. He can learn a DVT treatment, how to treat it, what says the evidence, what are the complications, how to deal with complications, and they can learn that intervention is not everything. An intervention without good post-op follow-up and compression and support is nearly nothing. So I think everything venous will be covered there.
Okay.
So just very fast, not very young patient, but young, suffered from a PAD 2-3 years after a below-the-knee bypass. He had the wound healing in the lower leg. So nobody approached his venous system, his deep venous system, and nobody realized that the guy suffered from a DVT years ago. And that was on the right side, bottom, that was the picture as he came to us with the full picture of the PTS. That was his venous map showing you the occlusion. We performed the MRV, and then we went for the phlebogram in the...
May I interrupt you just because, many people here are not very familiar with the deep venous interventions. If you go back one slide, I guess we're going to discuss more about it in the workshops, but many people here would only bother about the great saphenous vein incompetence. So you see here, you show great saphenous vein incompetence, yet you don't bother about it and you go directly to the deep venous system. Other people might opt to go for the great saphenous vein first. Is this a mistake, taking care of the great saphenous vein first?
No, that is not a mistake, clearly not. This is my way to do it, and we will discuss about it in our workshops and our scientific sessions. We have one presentation in the scientific session addressing this problem. No, we discuss it also in many other congresses. We know this problem. Because I am focused on deep, I go first deep in this patient, and I know this patient had an occlusion of the entire iliac or external iliac vein and a part of the common femoral vein. But it doesn't mean that if somebody treats the GSV, it is a mistake. Even I know your cases and Nico's cases, if you treat the GSV, maybe the ulcer will also heal. So, but in this case, I started with a deep venous recanalization. That was the predilation, the stenting using dedicated venous stent. We also will learn about that. And the final angiogram, just check the before and the after completion angiogram. So in this patient, that was the post-op duplex. Still, it shows the reflux on the right side bottom, but that was before the procedure and on the right side after the procedure. And I show you what patient is telling us. This is German, but now it's written in English.
Angefangen hat diese Glaubenskrankengeschichte nach einem Beinbruch. Damals bildeten sich große Einblutungen in seinem Bein. Blutgerinnsel führten sogar im Laufe der Zeit zu einer Lungenembolie. Vor der Stent-Operation hatte Peter Glaubitz massive Probleme. Sein Bein war extrem angeschwollen.
Also fast doppelt so stark wie normal. Man kann nicht laufen, es tut weh und man ist körperlich beeinträchtigt. Man kann nicht mehr runter an Fuß und nichts. Man kann sich da nicht mehr anziehen, waschen und so weiter. Die Bewegungsfreiheit ist immer nur auf Meter begrenzt, 20 Meter, 15 Meter. Man schafft nach Tagen jetzt vielleicht 50 Meter zu laufen, man muss sich ständig hinsetzen. Also es dauert Wochen, ehe man da wieder ein bisschen fit wird.
So you see how impaired this patient is. It is not just an occlusion and a venous hypertension which created the venous ulcer or non-healing wound below in the lower leg after the bypass. The patient is really suffering. After the procedure, opening the iliac tract and the common femoral vein, the highway is now open, the patient is doing really well. So I think with the time, I have a second case, but I will skip it because I would like Professor Afgarinos to show his case. Thank you very much.
Well, thank you, Human. That was a very, very nice case that you showed. By the way, do you want to tell us what is your protocol? Aside from anticoagulation, I mean, many of these patients may have to stay on anticoagulation lifelong. How do you handle compression? What are your instructions? Do they get the stocking immediately after the procedure? What strength and how long? Is it also lifelong compression? Is it below the knee? Is it above the knee? What are your instructions in general?
So you address now really many important points. So the post-op support and evaluation is mandatory. Anticoagulation is very, very important. We start always one day before the procedure, independent if we do the hybrid or not, with the full oral anticoagulation, if the patient is not anyway on lifelong anticoagulation. And immediately after the procedure, we put the stocking grade 2, compression stocking grade 2. It is tied to long, so upper leg for the first 2-3 months, and that it will be changed to the knee high. The grade 2 compression is very important for us, and the early mobilization of the patient. So it is mandatory. We go to the ward after the procedure and we talk to the patient. Many of them, are a little bit on the back pain because of the stenting. But of course, that is a main pillar of our treatment.
Swat, I think, has also a question, and then we should have Nikos Labropoulos comment. We may be running out of time, so I might not present for now. But go ahead, Swat. Well, maybe he's not listening. Nikos, do you have any comments?
Very quickly, address the comments that made by you, Maki, and the response from Human. This patient we saw here clearly has disease that cannot, if you were to look at great surface vein alone, it could not explain, right, the magnitude of the signs and symptoms in the lower extremity. So this is a patient where definitely you have to treat the deep vein obstruction, right? Because the great saphenous cannot give you swelling that goes up to the knee, and it cannot give you pressure change that go up to the knee or ulcer in that location. However, subsequently, when you deal with the deep veins, right, then you can address the great saphenous vein as well.
But Nikos, that was 3 years ago. You are fully correct. But the ulcer healed and the patient is lucky, so the reflux is there. I do not know if it's less. In the phlebogram, it seemed to be less, but you know, it is just a momentum. In the duplex, it was still there, the reflux, and we didn't address it, and he's coming once a year now.
I'm not saying you should, but I'm saying, you know, nothing to lose in a patient with such skin damage to address the reflux as well. What you did is correct. You took care of the deep veins that will explain, like, you know, or basically make the patient to feel better. Now, come to the compression. People like him, even if you do all the perfect treatment, take the saphenous out, cure the obstruction, patient has remaining deep vein disease and is going to be with swelling that cannot be never healed. So this patient should be controlled by proper compression that for a lifetime, like you suggested. Okay. One other thing I want to ask you, Human, is did you see any difference in the reflux in the saphenous vein before and after the correction of the deep system?
Yeah, I told you that. Yes, in the OR, in the phlebo, if you really focus on the phlebo before the recanalization and after, yes, in the run, the reflux is less. Even the reflux in the internal iliac vein was less, clearly less. If you just from the radiological point of view, mention it and compare it. But in the duplex, to be honest, I didn't mention the time, but I still see reflux.
Okay.
And another thing is, if we, in many cases, we stent the GSV, we gel the GSV, all of them are patent. So the reflux stays reflux and the non-reflux doesn't change to a reflux.
Let's move to Swat. Swat, you have a comment?
Hello, everyone. Thank you for also including me. Actually, I am now at Berlin for a health tourism fair. So I was at my stand myself. So Human showed the flag behind me since I am in Germany now. And actually, I would just ask the same question with you, Nikos, for the superficial part. But I just also want to highlight about the EVC's workshops, because you know that it's a European vascular course, its name. So the main difference from the EVC, from the many other vascular conferences, is just to bring the, mainly especially the afternoon for the young surgeons, the hands-on workshops. So anyhow, if you are not experienced, or anyhow, if you have some experience but want to improve yourself, these workshops are really dedicated, and you had a good chance to improve your skills and your information, especially as Makis also informed for the CT and MR venography. And since there are dedicated workshops, especially how to improve your decision making and how to improve your ultrasound skills, it is, I think, very important to not to miss such workshops and to participate. Since I think it's more than 12 years I'm participating EVCs. Before I was just a student participating, but now together with my very esteemed colleagues, I am a part of the venous part, and every year still we are continue to learning a lot of things through those workshops. So I just wanted to highlight this as well.
Thank you, Suad. So just a question to Dirk and Mahmoud, because of the time, I would love Makis to show a case, even if it's very fast. Is it doable or not?
Totally doable.
So I have this 74-year-old female. She has since 74, and nobody ever told her that something may be going wrong with your deep venous system. To make the long story short, she has left great saphenous vein insufficiency, similar to your case, Human, but she also has chronic changes at the common femoral and external iliac vein, multiple collaterals. In my institution, we are better doing CT venograms. Look at the chronic lesions of the left iliac axis. You see how minute the left external iliac vein is. And going further down, Of course, we decided to intervene. Similar thoughts like yours. We wanted to deal with the deep venous system first, accessing the femoral vein. You can see the first venogram, multiple collaterals, stenosis at the external iliac vein, and then trying to navigate our wires up. I typically use a glide wire. Look, this is very impressive. The crossover to the other side. So the left leg is draining through the right leg. So I pre-dilate with a big 12mm balloon. And then you look at the waist of the balloon up at the common iliac. This is a 14mm balloon. We do IVUS to exactly define the landing zones. And then we decided to deploy stents. I mean, you can start from top to bottom, or you can start from the bottom to the top. These are like little details we're going to discuss during the workshops. This is a dedicated venous stent. This is a 12x80, opening it up down to the common femoral vein. Yes, many people may find it weird that we deploy stents in the common femoral vein. Yet this is the way it needs to be done when you have disease at the common femoral vein. More to be discussed during the workshops. And then you realize there's still disease at the common iliac vein, so we have to deploy another stent more proximally. This is a 14x150, overlapping with the previous stent. We do post-dilatation, again aggressively with the balloon. And now look at the nice final result. You cannot see the collaterals anymore. And this is a very good indicator that we've done the job the right way. The contrast follows the path of the least resistance. Looking also at our landing zones, proximally and distally. And we felt this is a very nice result. IVUS confirming the patency of the stent. And look how the ulcer gradually improves over time. Now, I also dealt with the peri-ulcer varicosities. I actually ended up doing the entire great saphenous vein with foam, but I think Tobias Hirsch is going to give us more details into how we should be doing foam sclerotherapy. But we had a very, very nice result. And with that, I think we can discuss if there are any questions.
Mike, is very quickly something. You know, here is one of the cases. I don't know the full story of the patient, but the patient probably had a stenosis that was, for a long time, that was an innocent bystander. And from what I see, the patient, you know, on X-ray has a total hip replacement and probably developed thrombosis, right? And the combination now, the major surgery plus the stenosis, leading to chronic problem to ulceration. And obviously, you are forced to address the problem right now.
Exactly. So many times patients do not know that they had a DVT in the past. But if you ask them, did you have a major surgery? Did you have a major accident in the past? This is when, and they say yes. This is when you suspect they may have gone through a DVT that went unnoticed over time.
So, Makis, very fast, how are those stents you use? Can you use any stent below the ligament and put it in the common femoral vein?
So we should only be discussing about dedicated venous stents right now, okay? We should not be using arterial stents anymore. Now, we typically say that interwoven stents may be better, like the wall stent or the blue flow stent, may be better below the inguinal ligament, but actually there is no data indicating that one stent is better than the other below the inguinal ligament. I personally feel comfortable deploying any dedicated venous stent below the inguinal ligament when I have to.